Thank you for joining us today for Modifier Monday, Modifier KX, and some of its multiple uses. My name again is Mary Sue Gardner, and I will be your presenter for today's event. So there are a few housekeeping slides that I will go over as we start this event. And the first one is our disclaimer slide. We prepared this education as a tool to assist our provider community, but keep in mind, Medicare rules often change. Our education today and the responses that we give today are based on the laws, rules, and regulations as they stand today. However, if those happen to change tomorrow, it's your responsibility as a Medicare provider to make sure you are following the most recent and the most current laws, rules, and regulations because they will determine final coverage. Also, you're prohibited from recording this event for profit-making purposes. We are recording this event for you, pending the outcome of the call right now or the one from this morning. One of the two will be posted as an encore to our YouTube page for you to view later or to refer a colleague to if they were not able to join the live event. So if you're following along on the slide deck, the next slide is the acronym slide. This is just a list of acronyms that I may refer to in the presentation. So if I happen to use an acronym that you don't understand, you can refer right back to this slide. All right. My overall objective of today's event is that you learn about the appropriate uses of the Modifier KX in various Medicare covered services. And we're going to achieve this objective by reviewing those most common services that use the KX modifier. There may be other uses that are not listed in this presentation, and should you have questions on those uses, you can put those questions into the chat. If we don't know the answer today, we may let you know we don't know the answer, but we will figure out the answer and we will put it out in a follow-up document that goes out to all participants of today's event. Okay. Using the KX modifier actually notifies the claim processing system that the provider's documentation supports the payer's requirements for payment. So therefore, lacking that supportive documentation, misapplication of the KX modifier could lead to charges of abuse or fraud should one be caught as a result of a pre or post payment audit. So use of the KX modifier is similar to a traffic light. A green light signals that the payer is good to go and go ahead and process the claim for payment. The lack of the KX modifier is like a red light, informing the payer that you actually lack the required documentation for payment. As the description of the KX modifier indicates, requirements for its use vary from policy to policy. In some policies, the modifier pertains to all HCPCS codes. In other policies, it applies to only select codes. In some policies, the use of the KX modifier refers to very limited information. Like, for example, in glucose monitor policy, and indicates whether the patient uses insulin. Whereas in other policies, it attests to multiple criteria being met, such as the use of power mobility devices. In some policies, the absence of the KX modifier will result in a medical necessity denial, while in other policies, the lack of the modifier results in statutorily non-covered denials. So we're going to talk about some of those most common specific uses of the KX modifier. So as we move on, and if you're following along in the slide deck, I'm on the slide that starts with podiatric usage. So in podiatric services, there are several uses for the KX modifier. This includes claims to the DME contractor for Medicare. All HCPCS codes listed under foot ankle arthrosis or AFOs, which includes the L19000 to the L4397, and orthopedic footwear, which is the L3000 to L3649. Those policies require the KX modifier for payment. So if the podiatrist provides the following services and has proper and verifiable training, which became effective 8/30/21, the modifier KX applies to the procedure codes that are listed here on the screen, starting with the 64575, 64580, etc., all the way to and including the 64913. When these services meet the requirements, you would append the KX modifier. Okay, sorry, my computer got kind of caught up there for a second and things didn't want to happen the way they should. Okay, so again, we are not the MAC. We are the Part A, Part B processing contractor. So some of these things I'm going to tell you about the use of the KX modifier are specific for DME contractors, but I feel they're important. I want you to be aware of them. But we may not be able to answer specific questions on those. Okay, so the KX modifier with the CAR T cell therapy. So chimeric antigen receptor, or CAR T cell therapy, is a way to get immune cells called T cells, which are a type of white blood cells, to fight cancer by changing them in a lab so they can find and destroy cancer cells. Medicare covers treatment of cancer with autologous T cells expressing at least one CAR. And I know that's all very technical and clinical in nature, but I kind of wanted to give some background on this. So the effective date of service for this coverage is on or after August 7th of 2019. The Food and Drug Administration put out an article called Risk Evaluation and Mitigation Strategies, and gives information about the approved facilities to administer CAR T. So the use of the KX with the known procedure codes applies in this situation. Now, on your slide deck and contained on the screen here is a link to an article, and I'm going to hopefully open that article and link out if my computer's going to play nice, but it looks like it might not be playing nice in this case. I'm going to select my jurisdiction. I apologize because my computer is running really slow, and I'm linking out to this chimeric antigen receptor CAR T therapy billing instructions. So we have further instructions on our website for you in billing for the CAR T therapy. So Medicare allows billing of professional services under Part B with the dates of service January 1st, 2022 and after. All that information is listed up here as well. And the procedure codes are also in the hospital outpatient coding and billing chart that's listed here as well. One thing to note about this are items with an asterisk listed next to them. They need the KX modifier. So the KX modifier in this case attests to services provided by an FDA REMS facility. So failure to append the KX modifier will result in denial. All right, let's go back. I'll move this out of the way. And go back to the slideshow. All right. Now, one of the most common uses, and one that many of you may know about, is the use of the KX modifier as it pertains to outpatient therapy. So in outpatient therapy services, it's a billing modifier that refers to an annual per beneficiary incurred expense amount for outpatient therapy services. And that includes PT, OT, and SLP services. So when this billing modifier is appended to an outpatient therapy claim, it's an attestation of medical necessity by the therapy provider. By appending the modifier, the therapist is indicating that although the patient has received therapy services that have met a yearly threshold amount, that continued care is medically necessary. Not only is the therapist attesting to the fact that continued services are medically reasonable and necessary, but they're also attesting to the fact that they're maintaining the required documentation to support the medical necessity of these services. So let's look a little further at the therapy information. I want to give a little bit of background on the therapy thresholds. So back in February of 2018, the Bipartisan Budget Act of 2018 was signed into law. And one of the provisions of that law was regarding Medicare payment for outpatient therapy services. This included, again, PT or physical therapy, speech-language pathology or SLP, and occupational therapy or OT services. And it repealed the outpatient therapy cap and exception process, but it added limitations to ensure that patients still receive appropriate care even if it's above these thresholds amounts. So again, those former therapy cap amounts are now referred to as threshold amounts. The first threshold amount is the actual KX threshold. So this is the lower amount of the two outpatient therapy thresholds, and this is a monetary amount of service provided at which the KX should be appended to the claim. The lower threshold can change from year to year. So it's indexed annually by Medicare on an economic index or MEI. Each year there is an amount set, and that amount is for PT and SLP services combined. So that's one amount for PT, SLP, and one amount for OT. For this year, 2023, that threshold amount is $2,230. So $2,230 in PT and SLP and $2,230 in occupational therapy. In 2024, that threshold amount is proposed to increase to $2,330 for PT and SLP and $2,330 for OT, so a $100 increase. But the official amounts each year get published in the final rule. So along with the KX modifier threshold. There's also an upper manual medical review threshold, and that threshold amount is $3,000. So a review is not automatically going to happen at the $3,000 mark, but a review could happen at that mark. Targeted reviews are used for this, and targeted medical review means that not all claims exceeding that medical review therapy threshold amount are subject to review as they once were. So this limits the reviews to those providers that are outliers or those with questionable billing patterns, and sometimes brand new therapists, because they don't know what they don't know yet, sometimes fall under those reviews. Again, the amount for the manual medical review threshold is $3,000, and that's for PT and SLP combined, and $3,000 for OT. And that threshold, the upper level, is going to remain the same until 2028. At this point, the provider must also be continuing to report the KX modifier on the claim. So kind of let's just re-wrap up what I just said with all of this on your screen. Outpatient therapy, threshold amounts. Once you are getting close to or meeting that lower threshold amount, which is $2,230 for this year, we'll go up to $2,330 for next year, you need to start putting the KX modifier on your claim. And continue appending it to your claim even if you surpass or meet this upper threshold amount. All right. So the next most common use of the KX modifier is screening colonoscopies. So providers should append the KX modifier to screening colonoscopies, and the codes here, the G0105 and the G0121, if the screening follows a positive result from a stool-based test. So there are several procedures that fall, or several procedure codes that fall into that stool-based test, like the G0328, which is the colorectal cancer screening, or the fecal occult blood test. There is the 81528, which is an oncology screening, and that is quantitative, real-time, and signal amplification of 10 DNA markers and fecal hemoglobin utilizing stool. So Cologuard would actually fall into that category. And then there is the 82270, which is blood occult by peroxidase activity qualitative. And that's one of those that are provided 3 cards or a single triple card for consecutive collection. So that falls into there. And then again, on a lot of the screens that you have, either in your slide deck or that you're seeing on the screen right now, I have links to transmittals or articles or whatever that if that I'm talking about applies to what you do, you can find additional information. So this one happens to go to transmittal 11865. And if you want additional information about the use of the KX modifier on screening colonoscopies, that is where you could find that additional information. So as we move on, let's talk about gender-specific billing. Now, this is for Part B providers only. CMS may reject or return Medicare Part A and Part B claims inappropriately if it appears there's a mismatch between the procedure or diagnosis code and the reported sex of the patient. So this is a reminder to institutional providers and clinicians that bill for Part B professional claims that there are condition codes and modifiers that are available now to allow these claims to process correctly. So effective July 1st of this year, the National Uniform Billing Committee revised Condition Code 45 to gender congruence, defined as characterized by a marked and persistent incongruence between an individual's experienced gender and sex at birth. So for any procedure codes often considered appropriate for only one gender, you want to indicate on the claim detail line if the patient's experienced gender is different than their sex at birth. That's for your claims to process correctly. So if you are an institutional provider, you would continue to report the Condition Code 45, which is ambiguous gender category for inpatient and outpatient claims that are related to transgender, intersex, and gender expansive system issues. If you are a clinician that bills for Part B professional services, you would report the KX modifier for any claims that, again, are related to transgender, intersex, and gender expansive system issues. So if you feel that it might generate a system issue because the sex at birth and the sex identified with are different and the claim might not process correctly, that's when you use the KX modifier if you are Part B, and you continue to use Condition Code 44 if you are Part A. Here again on your screen and in your slide deck is an article to the MLN Connects article from June 8th of 2023 if you want more information on that. Oops. All right. So one of the next areas of use of the KX modifier, and this happens to be a big one, is diagnostic facet joint injections. So facet interventions performed in the outpatient department of a hospital are now part of a prior authorization process for Medicare. So when you're requesting prior authorization of facet interventions that will be performed in the outpatient department of a hospital, it's important that providers use the prior authorization request form that we provide for you. And this helps to ensure that the request does not miss any of the necessary components. For facet interventions, the KX must also be appended in the modifier section next to the CPT codes for diagnostic facet interventions. So down here, or if you are using our provider portal to submit your request, one of the places you would list the modifiers is down here under the service-specific information. It's pretty much the same if you're using the hard copy or if you're using the electronic version. But you should note that if you're doing the diagnostic facet interventions, you should also be reporting your KX modifier here. Now, it's not necessarily a make or break when it comes to the prior authorization, but it will be a make or break if you receive a affirmative decision to go ahead with the facet intervention, the diagnostic facet intervention, and you go to billing. So you will have to have it on your bill. So the easiest way to remind you to make sure it's put on the bill is start it from the start. When you're doing your prior authorization request, make sure it's on the request form. Once it's approved for prior authorization or you get an affirmative and a UTN to go ahead and proceed, then make sure that when you go to bill that it is on the bill as well. So in most cases, the KX modifier is only going to be used for those 2 initial diagnostic injections. If the initial diagnostic injections do not produce a positive response, like our LCD defines, and are not indicative of or an indication of the pain generator, excuse me, and it's necessary to perform additional diagnostic injections, let's say at a different level, you would still also append the KX modifier to the line. So aberrant use of the KX modifier may trigger focused medical review. I just want to let you guys know that as well. So in this case, CPT code 64490 through 64494 with the KX modifier will be limited to no more than 4 sessions per rolling 12 months. And that's all listed in our LCD as well. So the basic requirements is generally payment modifier first. So modifier 50 or 78, etc. And then followed by your sides if you needed an anatomic or right and left modifier, and then your KX. So again, here is a link to an article in your slide deck on how do we tell the MAC what type of facet procedure we are requesting and do we use modifiers. All right. There we go. Our next area of service that the KX modifier is commonly used in is cardiac rehab and intensive cardiac rehab. So inclusion of the KX modifier on the claim line or lines will be accepted as an attestation by the provider of the services that documentation is on file verifying that further treatments beyond 36 sessions of cardiac rehab up to a total of 72 sessions meets the cardiac rehab coverage requirements. So in this case, you append the KX to the appropriate cardiac rehab codes. So as contractors, we shall accept the inclusion of the KX modifier on the claim line or lines as an attestation by the provider of the services that you do have the documentation on file verifying that further treatment beyond 36 sessions and up to 72 sessions meets those policy requirements for either cardiac rehab or intensive cardiac rehab. Anything further or beyond 72 sessions within a 126-day period, counting from the day of the first session or for any session provided after the 126th day from the date of the first session, should meet the requirement for medical policy. So beneficiaries who switch from intensive cardiac rehab to your traditional cardiac rehab may also be eligible for up to 72 combined sessions with contractor discretion for cardiac rehab after, those initial 36. In these cases, and consistent with the information I told you, the KX modifier must be included on the claim should the beneficiary participate in more than 36 cardiac rehab sessions. All right. And finally, inappropriate uses of the KX modifier. There are some instances where the KX modifier would be inappropriate to use. This includes when services are just not allowed based on statute. So they're statutorily excluded, which means they're never covered, and using the KX on the claim would just be inappropriate. Also, when the medical record really would not offer any more data than is already contained on the claim form. And one example that's easy to think of in that is reference laboratory bill. So in the reference laboratory, they probably don't have anything more than the request for the test. So they may not have any additional documentation on file, you know, except for that electronic order to support the need for the test. So you would not use the KX modifier in that case. So at this time, I am going to ask Rachel if we have any questions that have come into the chat. Now, keep in mind that, as I said at the beginning, there are some instances when the KX modifier is used and we did not go through those today. So if there's questions that we can't answer, we will take those outside of this and we will send those questions and answers back to everyone that participated. So Rachel, have any questions come into the chat?
Yeah, we have one. And the question is from Ashley. Would the KX modifier apply to the 4538X CPT codes when coding them after a positive stool screen? Or would it be just those codes meant the G0121 and G0105?
Okay, so for the, trying to get my screen back. So for the screening colonoscopy, is you are doing the screening colonoscopy, it does only apply to the G0105 and the G0121. And that again is after those like positive stool-based tests. And those stool-based tests included the G0328, the 81528, and the 82270. So I hope that answers it, but it applies just to these two colorectal screenings after that positive, like fecal occult or one of those 3-card, you know, ones, or the Cologuard.
Okay, awesome. So then we have a follow-up from that. So if it turns diagnostic, then we would add the PT modifiers like we normally do.
Yes, that is right.
Okay, so otherwise, we do not have any questions in the chat so far.
I do see a question came in. One of our patients received therapy for immune deficiency. We were told to build the KX for the J1555 and the A4222. What policy does this relate to? And I'm not exactly sure, Melanie, if it relates to a specific policy, but one thing I do want to show you, and let me bring up the WPS GHA website.
That would be for IVIG. I don't know if we have a policy specifically for IVIG, but that is what the code is for, at least. If that helps at all.
All right. And what I'm going to do is we're going to look it up. Since Rachel and I don't specifically know, I went to the WPS GHA website, and I'll kind of walk you through where I went to. And I clicked under policies, and I went to our local coverage determination page. And I'm going to take that first code, and I'm going to drop it right in here and hit search and see if any specific any specific policies come up. And that one did not. Rachel does believe these are part of our IVIG policy. Let's search this one, and I didn't find anything there.
Their IVIG codes, I'm not certain if we have a policy. I think other contractors may, but I don't know if we have anything out there relating to IVIG for WPS.
All right. And we'll just wait for our little list to come up, but since we know that that's what they are claims for, let's take a peek if we don't see anything specific for those. So it doesn't look like we would have a policy specific on that. Oh, we do have an immunoglobulins policy. So I would check any information there, but otherwise, Rachel and I will look into the use of the KX with those codes and see what we can find. On behalf of Rachel and myself and all of Provider Outreach and Education, I want to thank you for your participation in today's event. So you may now disconnect.